floor is yours.
Thank you. Well, I'm a vascular surgeon from Mexico, so even that I'm a vascular surgeon, I have a training for the endovascular procedures too. But now in Mexico, we do almost all the vascular surgeons do open our endovascular procedures, and we do almost everything like aorta to veins, so chronic limb ischemia. And it's because it's not like in another countries that you are very specific with chronic limb ischemia and you do only chronic limb ischemia, or maybe you do only veins. In Mexico, we have to do everything because we are very, very few vascular surgeons. And of course, if we are few vascular surgeons, cardiologists, interventionists, they have a lot of work with only heart, and sometimes they do some specific endovascular procedures. And radiology, interventional, there are few intervention radiologists there in Mexico. If we are like 600 for all the complete country. And so I do everything. Now I'm going to talk about veins, but specifically the vascular procedures like deep venous thrombosis. So I'm...
Among this group, how many people are surgeons? 1, 2, 3, 4, 5, 6, 7, and with Frank, one more. How many are trainee? Junior?
Fellow.
Oh, sorry. 1, 2, 3. You junior? Junior? Are you junior? No. And how many are radiologists or angiologists? Thank you.
And
Rebecca, you can go.
And cardiologists.
Ah.
Yeah.
Oh, cardio.
Thank you.
Good group. Thank you very much to be with us.
Well, now we have the right talk. Sorry. And like I told you, I do everything, but now I'm going to talk about the meta-analysis about endovascular procedures for DVT. So I have no disclosures. What is this talk is about the meta-analysis and the randomized controlled studies and the Cochrane library about DVT. And I guess is very important to know that, first of all, the diagnosis of DVT, who is going to perform the diagnosis. Sometimes the patients go under an emergency room, and the emergency doctor performs the ultrasound. And then after they perform the ultrasound, they make the call for the vascular surgeons or wherever he's going to call in the hospital to see this patient. So about the diagnosis of DVT, there are some meta-analyses that they perform 15 publications to the inclusion criteria. And they put that the emergency experience of the doctor who is going to perform the ultrasound is very important. So if it's not the same that it's an emergency doctor with a lot of years there doing the same thing, that is made by a fellow. So this meta-analysis, the conclusion is that the ultrasound performed by emergency physicians is sensitive and specific for the diagnosis of suspect DVT when it's performed by a trained emergency medicine specialist. There are two kinds of ultrasounds. I'm going to explain in the next slide that the 3-point compression ultrasound examination may be more sensitive than the 2-point ultrasounds. So what is the 2-point? They made two two specific areas that make the ultrasound compression, that include the popliteal vein and the comoral-femoral vein. And this is the explanation where there are going to be the examination at the 2 centimeters distal to the popliteal vein, and it's the trifurcation into the anterior tibial vein, posterior tibial vein, and the peroneal vein. And the second one is the common femoral vein. The third point includes the superficial femoral vein too. More or less the total, this is a fast ultrasound, so it took 5 to 7 minutes to see it. And if they have any questions or any doubts about the ultrasound, they go to a radiologist to make the full ultrasound. So the comparison in this randomized trial that compared 2 or 3 points of compression ultrasound, they said that the 2-point ultrasound had similar pool sensitivity and specificity compared to the 3-point ultrasounds, that the false negative are very, very similar. So this is the conclusion of this meta-analysis about how to make the diagnosis. What about the treatment of deep venous thrombosis? And the treatment is basically that the objective of this kind of meta-analysis, that is the main that we have, is avoid the PTS, the post-thrombotic syndrome, because we know that this is the most common complication, and it can result in significant morbidity for the patient with the material impact of their quality of life. So the evidence supporting the lytic catheter-based interventions, the LCBI, is undertaken for early thrombus reduction in acute proximal DVT for the prevention of post-thrombotic syndrome, is conflicting. So about the lytic catheter-based interventions are increasing nowadays. It's very common to use it. This kind of the summary is that existing evidence in a pool treatment effects. This meta-analysis of randomized controlled trials as in the efficacy of the lytic catheter-based interventions and to prevent the PTS. So the early thrombus removal may reduce consequent development of PTS. We know this for a long time, but we have this meta-analysis divide the 3 catheter-based interventions into 3 categories. The one is the catheter direct thrombolysis, directed based to the clot with thrombolytic agents. The second one is pharmacological thrombectomy, physically breaks down the clot, for example, with a high-power saline jet, that is the jet stream, or the aspiration technique that we have 2 different, and in Mexico we have Penumbra, we have now Clotriver, and combination of the use of lytic agents like the ultrasound guide. And the third category is the one that use mechanical means alone without the need of lytic therapy. So these are the methods of this meta-analysis. They have eligible criteria, that it's randomized controlled trials, first of all, articles that are reported to use this catheter-based, the lytic catheter-based procedures. And the third is articles reporting on adult patients with proximal DVTs, and that they are defined like a thrombosis involved femoral, common femoral, iliac vein, or iliofemoral DVTs. and articles reporting an adult patient's diagnosis with DVT, but presented 2 weeks of symptoms onset, and articles must include a follow-up period to determine the rate of PTS developed with the study group, and articles reporting quality of life. These are the inclusions criteria, and these are the excluded criteria. The excluded criteria is almost all the articles that they don't have a follow-up period. They don't have they don't report on the chronic venous outflow obstruction, or they are not available in English, and articles that they are using data from animals. So these meta-analyses are, the complete meta-analysis are 6 studies from 3 different trials were included in the systematic review: the post-thrombotic syndrome after catheter direct thrombolysis for deep vein thrombosis, that is the CAVENT study; the acute venous thrombosis, that is the thrombus removal with adjunctive catheter direct thrombolysis, that is the ATTRACT study; and the ultrasound accelerated catheter direct thrombolysis versus anticoagulations for prevention on post-thrombotic syndrome, that is the CAVA trial. That it's all of them are published between 2012 to 2021. All these 3 trials has multiple multi-center randomized controlled trials. So these are the 3 studies. Sorry. Like you can see, the biggest is the ATTRACT trial, that it's a number of participants bigger, that it's 691 is the participant of numbers. Most of them, they are male in almost all the trials. And the follow-up months, even that the ATTRACT trial, this is the bigger, is the shortest. It's only 24 months of follow-up. The biggest is the CAVENT trial with 60 months. So these are the procedure characteristics of included studies. Like I said, some of them are catheter direct infusion of some thrombolytic, in this case is Alteplase. And some of them, they have additional procedures that they used, not only the catheter, the lytic catheter procedures. So if you can see, some of them made balloon angioplasty of venous stenting or thrombosis aspiration. In the CAVENT trial, in the ATTRACT trial, they made some additional procedures like balloon venoplasty, balloon maceration, venous stenting, catheter aspiration, and thrombectomy with the use of angiojet or trellis system. Nowadays, we don't have trellis system. So, and the ATTRACT, we have another ATTRACT, is not only the ATTRACT in 2017, they make a new ATTRACT with Dr. Camaretta that is in 2019 that they made the same. But he made additional procedures too. And the CAVA trial is the newest, and they made some procedures, additional procedures like the angioplasty, venous stenting, thrombosuction, and endophlebectomy of fistula formation. So if we see here about the post-thrombotic syndrome, that all these trials are measured if we can avoid, or how much we can avoid the PTS, and they divide it into moderate or to severe PTS. So if we can see, the definition of PTS depends on the trial, because on the ATTRACT trial and CAVENT trials, they use the Villalta score that it's 5 or higher on the presence of an ulcer and the ipsilateral lower limb more than 6 months after DVT. And the definition of post-thrombotic syndrome in the CAVA trial was according to the Villalta's criteria, but which required 2 time space more than 3 months apart, assessments of Villalta score of more than 5 and more than 3 months after DVT. What about the risk of bleeding? Like these trials, they used thrombolytics. Well, they have to say something about the major bleeding. After all, these 3 trials show us an increased risk or major bleeding. The ATTRACT trial reports 19, that it's 5.7% of major bleeding events. Compared with the group that is treated with anticoagulation alone. So the CAVANT and the CAVA trials had 3.3% and 4, that it's 5.2% of major bleeding events, respectively. And it's compared with no one on the control arms. In the pool analysis, the lytic catheter procedures, they have a risk, a major risk of major bleeding, but even that is a risk, no bleedings at the end were fatal. What about the discussion? Okay, this result of this meta-analysis shows significant reduction of the PTS and moderate to severe PTS for those undergoing 2 lytic catheter procedures. And for iliofemoral subgroup analysis, rates of both PTS and moderate to severe PTS were lower than the lytic catheter procedures. So we can see that the findings demonstrate that the efficacy of this type of procedures in preventing PTS were less than anticipated. And what is a successful thrombolysis? The definitions in each trial is the same. They say that some of the trials were successful, the thrombolysis, where they don't have any thrombus behind, or maybe they have thrombus behind, but there is a small ones, or maybe that they have a good patency after the thrombolysis. So the conclusions are these lytic catheter procedures are to reduce the development of PTS and moderate or to severe PTS, as we can see on the Villalta score. However, the magnitude of the risk of the reduction is not as large as previous thought. The decrease of PTS and development are accompanied by a small but significant increase of major bleeding complications, even that, like I said, there is no fatal complications. And we need further trials using contemporary devices and techniques to address early thrombus removal with a lower risk or major bleeding can achieve by as it's required. Thank you.
Thank you very much.
Yes.
Thank you very much for this very good and extensive preparation. I have a request of 3 questions in one, and can you answer very fast?
Yes.
First, is it normal that a surgeon does his or her own ultrasound examination?
Excuse me?
Is it normal that a surgeon does his or her own ultrasound examination?
Okay, for example, I have my own ultrasound, so I do.
So you do?
I do.
But it's very rare. It's very rare. The surgeon don't do that usually.
Okay, for me it's my tool of every day.
How many people you know doing that, even in international?
International, I don't know, but in Mexico...
Very few.
Yes.
So congratulations. Second question, very fast. Which are your contraindications of thrombolysis?
Like that depends on the patient, like always. And if it's an elderly patient, I saw that there is more risk of bleeding. That's one of my contraindications. And the second one, for example, for the echoes, that it's ultrasound and catheter thrombolytic, that it has to be under the ICU to check the coagulation times and everything. So depends on the patient and if he can do it or we can do it.
For instance, do you do thrombolysis on a patient of 85 years?
Depends on the patient.
Okay, it depends on the patient.
Yes, if it is in a good condition and you can see that it's gonna be, if it's a patient that is doing exercise and this is going to, you are going to leave him with a PTS, of course I'm gonna do it. If it is a patient that it's in a house lying in a bed, I'm not going to do it.
I understand very well, it's a logical answer. Third question, very fast answer because there is somebody waiting for an answer. What is your anticoagulation treatment after thrombolysis involving angioplasty and stenting? Do you do something more than clopidogrel or aspirin? What do Eliquis? I don't know. What is your protocol after all these interventions?
Okay, if this is a stenting patient, I will do like all the stents, clopidogrel and anticoagulation, depends on what do I have. The new anticoagulation, rivaroxaban and doxaban.
Do you use?
Yes.
With aspirin or without?
Without aspirin.
Okay.
Without aspirin, yeah.
Thank you very much. Oh,
come on.
Because
of the risk of bleeding.
Yeah.
If you cannot do it, everything, you cannot give it only...
If you have a question, you go, and I would like some people ask question in the room, please.
Yes.
Only one question.
We have time. My question is, what is your preferred device nowadays for DVT treatment of iliofemoral DVTs?
My favorite for DVT?
Your favorite device today?
Nowadays Inari, Clotriver is not, we cannot use thrombolytic. And it can take not only acute thrombus, you can clean old thrombus too. So for me, nowadays is my favorite.
Is there any...
I don't know if you have it here in Europe, Inari, like it's Clotriver.
Is there any question from the floor, from the room? Only one question, please. That means that you understand everything, so you are a good audience. Thank you very much.
Thank you.
Is that your turn? Okay, can you introduce him?
It's Dr. Dimitar Nikolov. Did I say it good? Thank you. Okay. And he's going to present thoracoabdominal aortic interventions.
In fact, I must apologize, but I will talk more about the complications in endovascular treatment of complex aortic pathology. This is the aim of the study, to share presentation to share some of the most challenging cases and complications we have encountered during our journey in the management of complex aortic pathology. Our journey began a little bit more than 3 years ago with this pararenal aortic aneurysm I must say that then and also now we don't have access to custom-made devices. So for this case, we decided to use a physician-modified graft with 2 fenestrations for the superior mesenteric and right renal artery with very good result. A year later, this is another case, again with endurant graft, bifurcated body, in which we had to use 4 fenestrations because of a practically absent neck and very close proximity of the all 4 visceral vessels, also with perfect final result. In some cases, fenestrations are not good enough, especially if the proximity of the endograft to the ostium of the corresponding artery is bigger than 5 millimeters. Branches are preferred. So we moved forward, and this is our first case in which we used 3 fenestrations and 1 short directional branch for the left renal artery. In this case, we're using endurant 2 aorto-uniiliac body, and this study, because of the narrow aorta, we use iliac extension with a fenestration in which we put practically C-wrap for the very calcified and diseased iliac arteries, and this is the result in this case. The appetite comes, and this is several months later. A lady with arch and type 1 thoracoabdominal aortic aneurysm. There is a previous operation with prosthesis of the ascending aorta, but we don't have a good enough proximal landing zone, so we had to go to Z0 part of the aorta. We decided to use 3 fenestrations for thoracic graft, again physician modified, and specifically the left subclavian fenestration is reinforced and precannulated for best alignment to the aortic arch. This is the very good result at the end of the procedure, covering the whole arch, beginning from the prosthetic ascendant aorta. But you can see that there is something interesting on the control CT. Proximally, everything is good. I don't know if you can mention this. This one? Okay, I'll tell you. In this case, the precannulated left subclavian fenestration required using of a 24 French sheet to accommodate the 22 French delivery system of the graft. And we had a pretty good, even for a lady, external iliac artery of 8.5 millimeter on the preoperative CD, but we felt some resistance during the removing of the sheet, and maybe you see what had happened. In fact, with the sheet, we take out the whole external iliac artery. It was over the sheet. It was stripped like a vein. So we were lucky to have true and true access, and immediately put a balloon in the common iliac artery, control the bleeding, and even more lucky, we had Viaban endograft 9x150, and we inserted with proximal beta sealing by B graft to the common iliac artery and directly anastomosed it distally, this is the femoral region, to the bifurcation of the common femoral artery. So this is the big save, I think, thanks to the ability to have this graft at the moment. What happened in this case? Because of the big sheet, 24 French, we thought that 8.5 millimeters of iliac artery would accommodate this size, but in fact, we must remember that 24 French sheet means 8 millimeter internal diameter, and usually these sheets have 2 to 4 French higher outer diameter, so probably this was the reason for interruption of the artery. So it's important to measure the correct diameters of the vessels and devices and always be prepared for access complications. So there are some key differences between fever and standard fever. As in the last demonstrated case, bigger devices are needed usually in fever and FTVR procedures, which is potential for access complications, but also manipulations in arch or visceral vessels, which are part of the procedure in fever, can result in more frequent target vessel complications. Of course, we have excessive coverage of the aorta, and this is potential for cerebrospinal ischemia. And if you rely only on PMEC, like I do, because of the only viable option nowadays, you can have issues like wrong measurements, malpositions, risk of infections, and also unknown durability. So the second case is of a 68-year-old male with pararenal aneurysm. You can see the CT. The aneurysm is beginning, one of the artery, the right one is going out of the aneurysm. We used Endurant 2 with 3 fenestrations. The cannulation was very quick and easy, 2 from below and 1 from above. And the result was pretty good. But during the night and on the next day, the patient became hemodynamically unstable. He had drop in the hemoglobin, and on the CT, we found that right kidney had a big hematoma and also retroperitoneal. And we did urgent right renal artery embolization in order to stop bleeding, but it was already too late, and the patient died several hours later. So what happened in this case? We were very happy with the relatively fast procedure, less than 3 hours, but after the successful cannulation of the renal arteries, when we revisited the pictures, we found that we did not change the stiff terumo wire with the less atraumatic one like Rosen, for example. We did not have control of the tip of the wire in the entire procedure, especially under magnification, the distal part of the wire, and we know that hydrophilic wires can easily make perforation to the kidney capsule. So it is very important. Don't ever skip important steps in these procedures. There are many small steps, but every one of them is extremely important. Use the right devices in the right for the right aims. This is another case with probably some wrong measurements and malposition. A 68-year-old male with juxtarenal aneurysm and occluded left iliac artery with absolutely no claudication. So we decided to use again aorto-uniiliac graft, Endurant, with 3 fenestrations. It was quite easy to cannulate the right femoral, right renal artery, from above, but after that it was very difficult to go from above for the mesenteric and the left renal artery. So we had to deploy the graft and go from the only access from below, because the other iliac artery is occluded, as you remember. But it was also very difficult to enter in the AMS or the left renal artery. And after more than 2 hours struggling, we decided to do laparotomy and directly puncture the superior mesenteric artery retrograde. You can see there is a big difference in the position of the ostium of the artery and the fenestration, but it was relatively easy to go from below to cannulate the superior mesenteric fenestration and proceed with stenting. Surprisingly, after that, it was very easy from the aorta side to cannulate the left renal artery and finish the procedure. So the result was technically good, but the patient had some issues: acute mesenteric ischemia, reperfusion syndrome, acute renal failure with dialysis for several days, prolonged ICU stay, but he finally survived. What we learned from this case, inaccurate measurements were the reason for this complication, I think. It was the wrong decision to cannulate the renal arteries first, and finally the laparotomy and retrograde recanalization saved the patient. The lesson is measure twice, cut once. In Bulgaria even we say measure 7 times, cut once. We, from this case later, always try to cannulate first the most important vessel, and opening in the abdomen should not be delayed if there is no other way to restore the mesenteric blood flow. The last case I will show you is about the excessive coverage. This is a patient with type 3 thoracoabdominal aneurysm, very ugly looking. You can see very angulated. The abdominal, infra-abdominal part of the aneurysm is 7.5 centimeters. He's asymptomatic but with quite big infrarenal aorta. So we decided to treat him with stage procedures. First TEVAR. The second step was physician-modified graft with, you can see, 1 fenestration for the celiac trunk and 4 fenestration because the left kidney had 2 renal arteries and the branches, I'm sorry, and the branch for the right renal arteries from the iliac extension. This is the final result. After the 3rd procedure, it is quite good, very good isolated. It was very challenging, be sure. But there is some small endoleak at the level of the visceral vessels, but very, very good isolation of the infrarenal aorta, which was the bigger threat in this patient. But 5 months later, this same patient had to go urgent surgery for a post-operative hernia with adhesions and some subileus. During this procedure, he had moderate blood loss. The next days, some hyperpyrexia and hypotonia. And on the 3rd post-operative day, he lost movement of his limbs, lower limbs. The vascular surgeon was not not cold even. More than 12 hours, and it was, of course, too late for anything. This patient stayed long in the ICU. After many days, he developed sepsis and finally died in days 62. What happened in this case, of course, the extensive coverage of the aorta probably gives high risk for the cerebrospinal insufficiency. hypotonia and anemia reduce the collateral perfusion of the spinal cord, resulting in spinal ischemia. And we know that even when we treat these patients well, with stage procedures, we can avoid acute cerebrospinal ischemia, but things like this can happen in any time afterwards if some factors provoke it. In conclusion, there are clear reasons why complex procedures have more complications compared to standard TEVAR. Thorough knowledge of TEVAR principles and techniques is essential. Every case contributes to the learning curve, and the greatest lessons often come from difficult or unsuccessful cases. And complication, in my opinion, should be carefully analyzed and openly discussed. Thank you for your attention.
Thank you very much, Dimitar. Please. I must admit something, and you must recognize something from Dimitar. He was honest and courageous enough to show 4 cases, tragic cases. This is the real world. Some people in a big meeting, they show you everything is nice. 5 arteries, revascularization. I'm one of the best of the best. No, this is the real world. And the best surgeon is not the one who show good case. This is the one you can save something after complication. On the 4 patients, you save 2. That's a good score.
But at the end, I agree with you, Jax, because it's difficult to talk about complications. It's difficult because not everybody has the courage to say, I have a complication and I did this and I tried this and I do that. And besides that, I agree with you that sometimes it has to be open surgery who saves the life of the patient, not only endovascular. So I guess sometimes we are very mind that everything is endovascular. But not yet.
Yeah.
Not yet is everything endovascular. For all the procedures, they cannot be. Or maybe if you have a complication, for example, I work with a interventional radiologist. All my cases are with an interventional radiologist that is more than my best friend since high school. So we are like very close. For the last 25 years working together. So if he knows that, I guess it's a good kind of couple, and then a vascular surgeon and a cardiology interventionist, so vascular surgeon and a radiologist, because if they have any of these complications, you can go and open it. And he talked to me like that, and he said, okay, I know if something happens, you are going to open it in that moment. I cannot wait, because he doesn't know.
Some lesion, respect the contraindication, don't do when you cannot do. There is no miracle in surgery, or very rarely. Second, be sure of your technique. Sometimes you have to be assisted by people like you do. And third, stay humble like you. Thank you very much, Dietmar.
Thank you.
I don't know if you have any questions.
No, there are no questions. There is never a question. I hope you will have at the end. Now it's a pleasure to ask Tatum Jackson. Thank you. Tatum Jackson is the granddaughter of Dr. Dietrich that I introduced to you in the opening session in the other room. She's a very brilliant vascular surgeon. She moved to Scotland and now England. Yes. And now you are English.
Yes.
Congratulations. And I remember a very good lunch that we have with your husband. And it's a pleasure to see you. I remember your grandfather. Thank you.
Thank you, Jacques. Right. As Jacques so kindly introduced me, my name is Tatum. I'm a surgical trainee currently working at the Sheffield Vascular Institute in the UK. I'm giving this presentation alongside my colleague, Jack Parker. A bit different topic, not necessarily about endovascular technologies, but the application of artificial intelligence and how that can help assist in different areas of endovascular technologies. Today and tomorrow, Jack and I will be presenting and focusing on endovascular planning for aortic pathologies and how his AI tech can do that. So I'll let him introduce himself.
Thank you, Dr. Jackson. Yes, Jack Parker, the co-founder of a company called Iatella. So that's an 8-person company based in Helsinki. And we exist to develop tools to automate manual tasks in cardiovascular imaging. The company started when I was shadowing an interventional cardiologist who was making measurements on scans of patients under surveillance for aortic pathology. And after his 6th scan, rather frustrating and getting tired, he turned to me and said a statement that caused me to found the company, and that statement was, "I didn't train for 15 years to measure aortas." So that's why we exist today. So that actually led to the first project that we did with a hospital in the NHS in the UK. So I theorized, can we automate these measurements that the consultant was so tired of making? So can we train an AI model to automate the measurements of the aortic valve area and that of the cusp commissure measurements? We trained this on 35 patient scans, so around 1,000 slices. Smile. And we were very pleasantly surprised to find a 97% accuracy with comparison to senior cardiologists, 3 cardiologists making independent measurements. Not only that, but it was achieved in over 100 times faster than the manual measurements. So that led to the further question, can we expand beyond the valve, beyond cardiac MRI, and can we go to the whole aorta? I'll let Dr. Jackson explain why.
So this morning, the focus is why use AI in interventional planning, particularly our preoperative measurements when planning for either TEVARs, infrarenal pathologies, or even fenestrated complex aortic cases. The main limitation is operator dependence, and that there's quite a lot of variability. It's been quantified and published in multiple literature reviews. Those 3 of note at the bottom of the screen do report a variability of more than 5.5 millimeters amongst expert readers of CT angiograms when they're measuring different diameters throughout the aorta, particularly areas of interest for intervention, such as the proximal landing zones. What the AI is able to do is automate these measurements, particularly through taking a center line through the aorta and then the diameters from that center line, which isn't necessarily, you don't do, when you do it manually, you're taking a diameter from an axial scan of the CT angio. So the AI is able to reduce that variability when taking those diameters. In addition, it's time. So where a very complex aortic case could take a vascular surgeon up to 60 minutes to plan what their intervention will be, their measurements, the graph they'll use, the AI can do this in 6 seconds with a full data output of 3 minutes. And I'll let Jack explain how his technology does that and what are some early results from our current aortic trial.
Yes, so what that output looks like. So this is a report generated from the actual CTA. This was generated in 6 seconds. So what the AI does is it segments, so it isolates the aorta from the CT angiogram. It plots that center line geometrically, so using that artificial intelligence, right from the annulus to the common iliacs, divides the aorta into 12 distinct regions. Within those 12 regions, the AI makes the maximum and minimum diameter and automatically reports those. However, the user can define exactly where along the aorta they would like that measurement, for example, the proximal neck and the actual whole length of the aneurysm itself. Dr. Jackson explained the importance of that center line, and I really want to double down on the fact that we generate that geometrically. We're not manually plotting that at all, and that's where the level of accuracy comes from. That allows us to make the measurements perpendicular to that center line for maximum accuracy. What is also generated are the screenshots of each measurement, so this allows the physician to review these measurements and not, blindly trust any form of automated tool. What it's actually measuring is the outer wall to outer wall measurement, as well as the lumen, including true and false lumen in the case of dissection. And as I said, perpendicular to the center line to maximize accuracy. And as you'll see here, this is a non-contrast enhanced scan because we also quantify the calcification in that same report. And as Dr. Jackson said, in those regions of particular interest, like the proximal neck, the user is able to track that measurement with the highest possible accuracy. The validation study, so now we've seen an output of the product, how are we actually validating that? Dr. Nikolov said, these trials can be done perfectly, but they don't necessarily represent the real world, and that's what we've tried to do from the start. So with populations across North America, South America, and also the UK, we've got 7 sites with 14 readers making 2 blinded measurements of the aortas of 450 patients. All of these images have been retrospectively acquired. We're using TAVI imaging and just aortic CTA. And as I said, they're making those 12 measurements in each of those regions. So it's basically AI versus human, and the question is, can the AI be as accurate and as reproducible, if not more, than the human readers? We also do a subset analysis by geography, by scanner, by manufacturer, and by age, sex, and demographic of the patient population as well. Early results coming out of this study echo the ones from the previous study, which is there's an over 97% agreement with the ground truth, and that ground truth being the measurements made by these senior physicians. Again, Dr. Jackson referred to the variability of us humans, us flawed humans. Even these expert readers are showing inter-observer variability of 3 to 5 millimeters, of which the AI is not. And again, that speed of reporting has been echoed with over a 200% increase in speed of reporting.
So why use AI in interventional planning? I think as Dr. Nikolov said earlier, we're measuring 7 times and cutting once. The AI gives us the efficacy, the accuracy, and the speed to measure once and confidently cut once. So it's the device sizing, reduced variability, and the time. Tomorrow, Jack and I will also give a presentation on post-operative applications of this AI in aortic interventions, particularly looking at risk analysis and detection of endoleaks. What do I want to say? Thank you, stent migration, and sac aneurysm forming. So we'll be speaking about that tomorrow. And that's the end. Thank you.
How many minutes do you spend for program and intervention? Do you say 3 minutes? For the
report to be generated, you said?
Yes, to have the result.
So that one was generated in 6 seconds, but
6 seconds.
on a real world scenario, just on any laptop you have, it's 3 minutes max.
Normally, I use like you. You draw in a paper, and you say, okay, I need this. So this program makes what we do, but more accurate. Accurate, yeah.
You are old-fashioned.
Yeah.
Thank you.
I'm old-fashioned. Yes, I plan my cases in a paper.
I have a question for you both, and maybe you. I heard moving around in the international faculty, I heard that you have many competitors on the same subject. There is one in France, Predisurge, 2 or 3 in US, one in China. I think that the competition on this topic is very hard. Do you confirm?
I'm glad to say that there are other solutions out there that are trying to solve the same problem, with the patient in mind. However, our approach is slightly more comprehensive than Nuria, for example, the French company. Predisurge doing the simulations of graft into the abdominal aorta. Our approach is the extensive measurement of the entire aorta from the start. So rather than identifying an aneurysm and then requiring the physician to go in and still perhaps do your hand-drawn measurements, all of the measurements are pre-reported. In addition to this tool, we also do longitudinal assessment. So if you have a patient under surveillance, rather than spending your time measuring.
Who will buy your system? The practitioner or the hospital?
In the UK and the US, the current customer is the hospital, as well as some kind of outsourced cardiology or telecardiology who assist with TAVI planning, so 3D labs are the customer.
Do you have one in Bulgaria like that?
No.
You expect something from the industry? No.
Very nice, of course.
Is it expensive, by the way? The system?
I can be honest to this group, the cost of an inference, so the cost of us to run one scan is less than €1.
Sorry?
Less than €1 to run the data on one side.
Oh, yeah. So if it's affordable.
The paper is more expensive.
Other question, no Ivo, because it's too good. Other question, the youngest, you will have to use that question, Rebecca. You.
Okay, I have a question. Yes, how easy is to do it? Because, you know, everybody has an iPhone or a cell phone. It could be used by a cell phone, it's easy, or you have to be in a computer.
So the technology would integrate directly with PACS. So as soon as the CT hits the PACS system, it basically gets fired up to the cloud or on the local machine. And
sometimes we
back
can
to
do
PACS.
it in the iPhone, for example.
Okay.
You can do it. We can see the.
If you can access
PACS
PACS,
studies.
yeah, then absolutely.
How long before the intervention do you do that? Immediately before or few weeks before?
That would depend on the user, so whenever they request.
But you have to order a graft after your application, so you have to do it a little in advance.
Yeah.
2 weeks or so. Okay. Do you proctor people? Do you go to the site to help people to proctor? Do you proctor?
Yes, yeah, we assist on site. Yeah.
So you travel all over the world.
Yes.
Lucky you.
Hence the grey hairs.
So you are 24 hours.
Pretty much. Pretty much.
Pretty much.
Yeah.
Okay. Do you have any questions?
Yes, I have specific question. It's very nice model, but do you work on, you know, when you put wires and grafts in the aorta, there are changes if there are big tortuosities. So is this model also take into account the changes from the grafts and the wires in very tortuous anatomy? You do you learn this model for these cases?
Yes, yeah. So we call that edge case scenarios. So we have an example number of cases of particularly tortuous aortas. But a key factor of our technology is it's constantly learning. So for example, if you do have a particularly challenging case, we can use that to aid and reteach the AI so that it's better performing next time.
Question in the audience, again, I just ask.
Can I ask you, sorry, just do you think...
Who speak?
Yeah, sorry.
Can you give your name and
Yeah,
your
my name
location?
Is, again, Dimitar, like Professor Nikolov, but it's Dimitrov. But I want to ask whether do you think you can expand this AI outside the aorta for the lower artery, for the lower limb arteries, or for the carotid, or for?
Yes, I like that word, carotid. Development is already underway for the carotids right through to the peripherals. So top to toe is the goal.
Was a question? So I go to Ivo. We have a few minutes left before lunch. What do you want us to do?
If I can just make a recommendation to anybody that is assessing any of these tools, please look at the training data that it's been trained on. As Dr. Nikolov said, it's all well and good a tool being trained on a Caucasian population in North America, but unless it's been trained and validated on your local population, be skeptical.
I would like to ask you to come 15 minutes before the next session, so after lunch. Instead of starting at 2, please come 15 to 2. We are going to say several words about as an opening ceremony, and it would be very good to be together for the opening ceremony. So thank you very much once again.